Today we will talk on CIDP, that is called chronic inflammatory demyelinating polyneuropathy or polyradiculoneuropathy, because it affects from nerve root to plexus to distal nerves. That is why they now also call it polyradiculoneuropathy. Okay. So what do you mean by chronic? So chronic means the course should be progressive, or it can be relapsing, remitting course as well. But the course should go over 8 weeks. So course should cross 2 months, and it can be progressive course or it can be relapsing, remitting course as well. Okay, in about 1/3 of the patients, the course is relapsing, remitting type. Okay, so there is not always progressive course. So that's what it means by chronic. Okay, and inflammatory means there is inflammation going on, immune mediated inflammation, both B cell mediated and T cell mediated inflammation against nodal and paranodal proteins like neurofascin, contactin, and due to this immune mediated inflammation there is demyelination. Okay, so that's why the more the myelinated nerve fibers, the more affected they are. Okay, that's why motor component is involved more than sensory, and among sensory, if you see, the vibration and proprioceptions are more affected compared to the pain temperature, because the posterior columns are more thick and myelinated compared to this spinal thalamic tract. Okay, so it is immune mediated inflammation that causes demyelination. And poly means it can affect limbs or any upper limb, lower limb, any part of the nerve can be affected. And radiculo means it can affect nerve root, plexus or peripheral nerves. It is not involved. It does not involve a spinal cord, but from root till the distal nerve it can be affected. Okay, so that is the meaning of this CIDP. And now let's talk about. There are two variants of CIDP. One is called typical CIDP, where you can see the typical course. Another is called variant CIDP. So a variant CIDP includes like pure motor CIDP, pure sensory CIDP, distal acquired demyelinating sensory neuropathy, okay, multifocal acquired demyelinating sensory motor neuropathy. Okay, so these are different variant CIDP, and this is typical CIDP. Why do we need to know? Because the treatment is different. We'll later see what are the treatment for typical CIDP and what are the treatment for variant CIDP. Because the treatment you give for typical CIDP may not respond to variant CIDP. Okay, so we have to know briefly about this typical and atypical CIDP. Now let's talk about the European guideline regarding CIDP diagnosis, that is called EAN-PNS guideline. Guideline. So according to this guideline, they have told that for a definitive CIDP, you should meet inclusion criteria, clinical inclusion criteria, clinical exclusion criteria, and electrophysiological criteria, that is the nerve conduction study. So there should be motor problem in at least 2 nerve that is tested. But for possible CIDP, that's detailed that you can have inclusion criteria, exclusion criteria, and if any one of the nerve affected, then it can be possible CIDP. Okay, so let's talk about those inclusion criteria, exclusion criteria, and electrophysiological criteria and supportive criteria, guys. Okay, so what are the clinical inclusion criteria? Clinical inclusion criteria. So I already told you that the course should be over 8 weeks. So 2 months and at least 2 limbs. So you can convert it to month, and you can remember like the course can be progressive, but can be intermittent course as well. But 2 months and 2 limbs. and deep tendon reflexes absent or decreased in all extremities. Okay, this is the inclusion criteria. For this is for typical CIDP, guys. Okay, and for atypical or variant CIDP, I already told you that there can be pure motor, pure sensory, multifocal motor neuropathy, distal acquired demyelinating sensory neuropathy, multifocal acquired demyelinating sensory axonal motor neuropathy. Like those we will not discuss. For while discussing about typical CIDP, and let's talk about clinical exclusion criteria. Clinical exclusion criteria, guys. So you can think like this way. CIDP is a diagnosis of exclusion. You have to exclude all other causes of either reversible causes or irreversible causes of neuropathy, because if reversible, then you can definitely treat that condition, and also you have to exclude other reversible causes. Like what are the what should we exclude? So one is diphtheria toxin, that causes neuropathy. Lyme disease can cause neuropathy. Drug exposure, toxin exposure can cause neuropathy. There is amyloidotic neuropathy. Okay, peripheral lymphoma affecting nerves, that cause neuropathy. Diabetic neuropathy. Okay, diabetic neuropathy. I am want to tell you here one thing. Like diabetic amyotrophy, there is lumbosacral plexus involvement. Okay, and in CIDP, that is focal CIDP, you can get also lumbosacral plexus or only brachial plexus involvement. So you can confuse there whether it is diabetic amyotrophy or it is CIDP variant. Okay, so you have to exclude diabetes before telling that it is due to CIDP, and we are now going to start immunosuppressants. Like in CIDP variant, you have to give Rituximab, guys. Okay, so that's why you have to. I told you that you have to exclude that condition. Okay, and if there is early sphincter involvement, sphincter involvement means bladder sphincter or rectal sphincter, then that also excludes CIDP, guys. Okay, so this is regarding exclusion criteria. Now let's talk about electrophysiological criteria. So electrophysiological criteria, you know that in nerve conduction study we test for motor nerve and sensory components both. In motor we test for ulnar nerve, median nerve, peroneal nerve, tibial nerve, and if you see the demyelinating feature, motor conduction block in at least two nerve, it meets the criteria, electrophysiological criteria for CIDP. But if you see in one nerve, then that is possible CIDP. So what are the findings you can get? So motor distal latency greater than 50% of upper limit of normal. Okay, or can be partial conduction block, or F wave latency prolongation, greater than 20% of upper limit of normal, or absence of F waves. Okay, so this is the motor component. If you get any of these in at least two nerves, then definitive CIDP. If only one nerve, then possible CIDP. In sensory component, it also somatosensory evoked potential is decreased and sensory conduction block is there. Okay, but this is the supportive criteria. Sensory component comes under supportive criteria, guys. So we discussed about electrophysiological criteria. Now let's talk about supportive criteria. So what falls under supportive criteria? So MRI with if you see the gadolinium enhancement in nerve root, plexus or nerves, or if you do USG of peripheral nerve, and you can find thickening anywhere, then that also is one of the supportive criteria. Another is nerve biopsy. If you see in the electron microscopy inflammation, demyelination, and inflammation going on in these nerves, then that also supportive criteria. Okay, and another supportive criteria is improvement with immunomodulatory treatment. Immunomodulatory, you start treatment and if you see the clinical improvement, that also supportive criteria. Okay, so MRI, USG, nerve biopsy improvement, and another is CSF analysis. In CSF analysis, if you see albuminocytological dissociation, I mean to say that protein is elevated more, but cell is not elevated. If you see the pattern like that, that also is supportive criteria. Okay. So we talked about inclusion criteria, exclusion criteria, supportive criteria, electrophysiological criteria, and this combination of permutations of these inclusion exclusion criteria, they tell that to tell definitive CIDP, you have to meet clinical inclusion criteria, you have to fulfill clinical exclusion criteria, and clinical and electrophysiological criteria should be in at least 2 nerves should be involved. Okay, but for possible CIDP, you have to fulfill inclusion criteria, exclusion criteria, but if only 1 nerve, if you see the electrophysiological involvement, then that is possible CIDP. Okay, so we talked about how to diagnose CIDP. Now let's talk about what are the treatment options available. So we have to treat early treatment. Why we have to start early treatment? Because you know this is the immune mediated inflammation, and if you delay the treatment, there can be irreversible loss of this motor or sensory nerve. So you have to suppress the immune system early. Okay, we can the treatment options are IVIG, plasma exchange, glucorticoids, and other immunosuppressants like Rituximab, mycophenolate, methotrexate, cyclophosphamide, cyclosporines. You know those immunosuppressants. Okay, so let's talk about IVIG. So when do you give IVIG? So if you desire early response, so if you want, if you see the course is rapidly progressive and you have to control the symptoms early, so for rapid response treatment, you can use IVIG like 0.4 gram per kg per day for 5 days. Okay, and you have to repeat this after 3 weeks. This IVIG, because this once you give IVIG for it, this also only controls symptoms for 2 to 6 weeks. Again, there can be relapse. Okay, so you have to repeat after 3 weeks. And another is plasma exchange. Plasma exchange also you have to repeat. You have to repeat after 2 to 6 weeks. Okay, and another is glucorticoids. So regarding glucorticoids, you can give oral or IV, but don't give daily. Okay, you have to give in pulsed manner. Okay, and this is for a typical CIDP. But if you suspect CIDP variant, like those I already talked, focal, multifocal, pure motor, pure sensory, multifocal acquired demyelinating sensory neuropathy, distal acquired demyelinating sensory neuropathy. In those conditions, you give Rituximab. This does not respond to IVIG, plasma exchange, or glucorticoids. So that's why it is called CIDP variant, because it does not respond to these typical treatments. Okay, and if we not responding to above, then we can try immunosuppressants, like I already told you, those immunosuppressants like mycophenolate, methotrexate, cyclophosphamide, cyclosporine. And suppose if patient does not respond to IVIG, then you can try plasma exchange. If not responding to plasma exchange, try glucorticoids. If not responding to glucorticoids, try other immunosuppressants, agents. And after you start treatment, you have to follow up the patients. So follow up, initially you have to follow up at least 3 months. But after it patient goes into remission, then you can follow up in 6 months. Okay, so why you have to follow up if patient goes into remission? Because I already told the course can be relapsing, remitting. Okay, so you might patient again might require immunosuppressants. let's talk about prognosis. So 30% of the patients goes into cure or remission. So about 1/3 of patients achieves cure with if you initiate this treatment in CIDP. Okay, guys, and about 18% of the patients has relapsing remitting course or progressing course. Relapsing remitting course or progressing course. So we till now what we talked. Let's recap. So we talked what is the definition of CIDP. We told you that for at least 2 months should be there, and to tell definitive CIDP, at least 2 limbs should be involved, 2 nerves should be involved. Okay, guys. So 2 months, 2 nerves, 2 limbs. You have to remember. You can remember like that, and it is immune mediated inflammation to nodal and paranodal proteins, and that leads to demyelination, and it affects more motor compared to sensory nerves. And in sensory nerves also, the more myelinated posterior columns are affected more compared to spinal thalamic tract, and it can affect from nerve root till plexus to distal nerves. Okay, so you can see the immune enhancement in gadolinium. If you use gadolinium enhanced MRI, because that helps to take you biopsy. For example, if you want to take nerve biopsy, then you can take from the areas where there is enhancement. You don't take biopsy from the degenerated nerve. Don't take biopsy from uninvolved nerve. So the USG of the peripheral nerve or MRI helps you to assess from where to take nerve biopsy. Okay, and the different modalities of investigation are definitely one is nerve conduction study. You check for motor conduction, sensory conduction. Other is MRI, CSF analysis. You can see alveolo-cytological dissociations. In USG you can see peripheral nerve thickening. And for treatment we can use IVIG, plasma exchange, pulsed glucorticoids. If not responding to that, you can use other immunosuppressant agents. And for variant CIDP, don't use those typical treatments like IVIG, plasma exchange, pulse steroid. You directly go for Rituximab. So if you think if you have any questions, you can comment down.